Welcome to Casual Conversations. I'm really happy to have you back. This is our second episode in our third season. And I want to thank IBIA and NABIS for giving us this platform, and for all the people at IBIA, Margaret, Jennifer, Megan, who all help with the emails. So welcome to our show. And I would like to introduce to you someone that has been very supportive of Pink Concussions. And I was just thinking, even found us in a meeting, I think it was in New Orleans, we were having a meeting about Pink Concussions, and you walked in the door. So welcome, Dr. Zasler.
Thank you. Nice to be here.
How are you doing today?
Good. How are you doing?
I'm doing well. Oops.
You look like you're on vacation, but I'm sure that's...
Yeah, it's all the fake Zoom, and the large puppy that's staying with me just found me. So I wanted to welcome you to the show. And what we usually start with is talking to people and asking how they got into brain injury. It's really not a rock star job where you get, expensive cars and invitations to Hollywood. It's one of the harder fields in medicine, because I don't think brain injury doctors get a lot of credit. So how did you get into the field?
You want the short version or the
long version? Sometimes we go back to childhood when I ask this question, and most people don't know the answer.
I will go back to childhood briefly. 12 years old is about when I decided I wanted to be a doctor. I went through the process, college, medical school, was in medical school in Chicago, did an elective rotation at what was then Rehab Institute of Chicago. And that was my first experience with rehabilitation medicine, or physiatry. And I really liked it because it combined a lot of the things that I enjoyed doing: neurology, orthopedics, internal medicine. And the big plus was that it had this philosophical approach of treating patients holistically, both from the evaluation as well as the management standpoint. And I also liked the fact of establishing relationships with patients and families, as opposed to, a surgical kind of approach where you go in, you go out, you're done, and on to the next patient. So that sort of triggered my interest in rehabilitation medicine. I applied actually for a number of residencies in rehab medicine. RIC was my first choice. I was dating a woman at the time who lived in Virginia, and I applied to the Medical College of Virginia, what's now Virginia Commonwealth University. I got in there and missed the spot at RIC by one spot, which ultimately turned out in my interest, because I was availed opportunities at VCU that I don't think I would have gotten anywhere else. And the rest is history. I worked under a gentleman by the name of Dr. Henry Stonington, who was the founder of the journal Brain Injury, and one of the initial people involved, along with Sheldon Barrall, a little brain injury history here, in starting the International Association for the Study of Traumatic Brain Injury, or IATSTB. And also worked closely with George Zitney, who then went on to develop the organization International Brain Injury Association. And I eventually was the motivator to have those organizations merge, and then was involved, as you may know, with IBIA for the last, 15 years at least, if not longer, in official positions, either chair or vice chair. And got involved with brain injury research early in my career, in my residency. And I guess the rest is history.
What do you think is the biggest change that you've seen in your years in the career of how brain injury was approached when you started and today?
You're saying in terms of medicine specifically?
Yeah, anything, approach, medicine, like what have been the biggest changes that you've seen around?
Not to be negative, but it's become more difficult for patients, I think, to access care, which is frustrating for me as a clinician, particularly post-acute care services in most communities. I think the science has advanced tremendously. I started this in 1985, so I've been doing it for a while. And we know a lot more now than we knew then, but we still have much to learn. I think some of the more exciting things have been advances in genomics, gene-related therapies, in inflammatory markers and biomarkers, in neuromodulation techniques for treatment of a variety of neuromotor and other disorders, including tinnitus and headache. Those are probably the more exciting areas. There's certainly other ones as far as robotic therapy that basically weren't around when I started doing this 30 plus years ago.
Well, there's so many different questions I want to ask at once, but I will talk to people whose brain injuries were 15 so on years ago, and they're really what seem to be wrapped around community care, transportation, year-long programs. I don't hear that today. I hear, you got 30 days.
Or less.
Right. So it seems that fewer people, and these are privileged people that have English as their first language, and their skin color happens to be white, and they have health insurance, and yet for this group it's even smaller, which I can imagine for marginalized communities there's even less and less.
Right. There's still significant healthcare disparities in TBI care. I'll give you an example in reference to the comment you made, Catherine, and that is when I started doing this, severe TBI inpatient stays could easily go 6 to 12 months back in the 80s. Now, the typical length of stay in the model system centers of care nationally is under 30 days.
Wow.
That's a big difference. And people are discharged home still in post-traumatic amnesia, which I think is ridiculous, but it happens regularly.
And is that a factor of the business and the profit and healthcare companies making these decisions rather than clinical decisions?
The disparity is that science isn't driving care, dollars are driving care, and payers are driving care, and they're not abiding by what the science says.
Right.
But we need to continue to advocate to change that, obviously.
And then with the science increasing, I've only been around 10 years, and there have been so many advancements. We generally say, 15 to 10 years from research to practice. Do you think that is the research getting into clinical care faster than it used to, or is that still lagging?
I think that there's been improvements in that sense, in that one, you have much more research going on in the general field of neurorehabilitation. I say that more broadly than just rehabilitation medicine. So neurology, neuropsychiatry, related disciplines, neurootology, neurooptometry, etc. So I think you're seeing more research done in general. I'm not going to say this is true across the board, but you see better prospective, methodologically sound studies getting done that are controlled and blinded. So I think we're putting out more and better science in general. I think that the translation of the science to practice still has a delay, but I think that that's sort of a natural, unless there's something so profound that's found that it goes directly to clinical practice. For example, the development, not rehab related, but the development of mRNA vaccines, rapid development. We have some examples of that, but I think in general, there's a multi-year lag between the science and the institution of those practices clinically in the trenches.
And how as an advocacy group do we speed that up? I mean, or whose role is it to speed that up? I've often said that I think a lot of the education happens by drug reps, and we really don't have that many I mean, I feel like they're carrying the message to a lot of, individual practices that they visit. I mean, I feel like, brain injury doctor, the conferences were very full before COVID. How do we get that translation time shorter?
Well, a couple of comments. I heard several questions there.
Yeah.
Number one, nothing against drug reps, but hopefully drug reps aren't the way that doctors learn about advances in pharmacotherapy. And they learn that from reading peer-reviewed journals. Number two, and I have no problem with drug reps. I just finished the drug rep lunch, but again, that's a marketing thing for the drug rep. It doesn't necessarily mean that you're being presented even-handedly the science. Number two, I think there's too little physician attendance at brain injury meetings, and there needs to be better participation and involvement of physicians in the context of both regional and national as well as international meetings. I've been doing this, as I said, for a long time. You tend to see the same people at those meetings. It's important for the younger folks to participate and learn. And I think dissemination of information is key. And there are multiple ways to do that, conferences being one, peer-reviewed publications being another, textbooks being another. And there certainly has been a increase in conferences over the years. When I started doing this, there were maybe 3 big conferences: Braintree, the Williamsburg Conference, and the Stanford Conference run by Jeff Englander. You now have a plethora of conferences available, both virtual and otherwise. At least with the pandemic, they were virtual. As well as international meetings like IBIA, which is probably one of the best meetings, along with national meetings like American Congress of Rehab Medicine, which is pretty focused on acquired brain injury rehabilitation issues. So those are 2 that I recommend. As far as advocacy, I mean, unfortunately, I think there's not enough of that, and there's not enough funding to advocate. Otherwise, we would see different practices by payers as far as science driving these decisions rather than dollars, as I mentioned before. I think that everybody involved has an obligation to advocate, whether you're a physician, a therapist, a family member, a patient. But again, advocacy also is to some degree a skill that needs to be learned in terms of how do you advocate and to whom do you advocate and where can you make the biggest difference. And I'd like to see more published just in that realm for everybody to be aware of and use in the context of their own advocacy work.
It's frustrating too, I think, where the science is better, there's more peer-reviewed evidence out there, and yet as a doctor, you're limited by insurance companies making decisions. I mean, how do you deal with that frustration?
I go home and complain to my wife. In all seriousness, I personally have limited my practice because I just became frustrated to the point. This isn't a good answer, but this is my answer. I have structured my practice in a way that I don't have to deal with a lot of the hassles of current day medicine. But again, that doesn't get to the root issue of how we serve all the people that get brain injured. And I think the sad thing is that we tend to be aggressive up front and save people's lives. There are certainly things we can talk about, acute care issues and problems with, for example, withdrawal of care prematurely, where prognoses are clearly not well evident, but yet people are making decisions about life and death day 3 injury.
Lori, could you mute, please? Thank you. I'm sorry. Please continue. Did I lose you? Where are you? There. Oh,
It's on mute.
yeah. Dr. Zasler, could you unmute?
I think I got muted for some reason.
Yeah, they were muting everyone and you got muted. I'm sorry about that. Could you repeat what you said?
I've been muted before.
No.
So what I said was, I don't know where I got cut off, so I'll just go back. There are multiple levels of problems, but we tend to be aggressive about saving people's lives up front, but we don't follow through and continue to provide care beyond that acute period. And if you're lucky, you get some rehab. These days, it's much shorter rehab, so people are being discharged more impaired, more disabled than they would have been 20, 30 years ago, given what I said before about the lengths of stay being much longer. And then there are typically a significant lack of services beyond that acute rehab period, whether day rehab, transitional rehab, outpatient rehab. And in a lot of communities, just a general lack of expertise, even about mild TBI or concussion, which is by far, obviously, as I think everybody knows on the call, the most prevalent form of brain injury, moderate to severe, making up only a small portion of all TBIs, 10 to 15%. So, I think there's a lot of challenges and a lot of problems in the current healthcare system in our country, and I will only speak to the US situation. Different countries have different issues, some better, some worse. I think we have the potential to be a lot better, but it's going to require legislation and advocacy to continue to try and change what is at fault in the system.
Right. And I think you're right. I can name 20 different brain injury organizations. There's so many little ones, medium-sized ones, and there's really no umbrella that everybody wants to follow under. And I think the fractured approach, Marilyn Spivak came on and said this, that the fractured approach isn't going to get us the power that we need to try to change the system. And I've watched in the field of addiction, in substance use disorder, Shatterproof is an organization that has been out ahead with millions of dollars and really been able to change some of how the insurance is handling the opiate crisis. So I think it does work if you have have the right approach. But so in this last segment, were you to be king of the world, what would you like to see besides reimbursements, which we've just kind of talked about? What are you excited about? What would you like to see? What are you looking forward to seeing in this next 5 to 10 years?
That's a loaded question. As far as clinical practice is concerned, I'd like to see a stronger emphasis in training younger and up and coming clinicians, whether physicians, neuropsychologists, therapists, nurses, etc., on the nuances of assessing and treating people with brain injury and the application of good differential diagnostic skills, which I think is lacking in the field as a general criticism, trying to be constructively critical. That's my short answer. I don't know if you have more specific questions, but that would be my succinct answer.
Well, and so then out of that, you have such a high level of knowledge that I also want to drop down and ask about headache. What do you think, what in the aspect of post-traumatic headache, what do you think what are the advances that you've seen that you're most excited about?
Well, I'll make a few points on post-traumatic headache. One, post-traumatic headache is a symptom. So a patient who comes to a clinician and says, I have headache, and the clinician diagnoses post-traumatic headache, that's not very helpful because it doesn't tell you anything that the patient and you didn't already know because they told you they have headache and that it followed a trauma. It doesn't give you any information about how to treat the patient. So don't accept that as a diagnosis. It's kind of a garbage can diagnosis like post-traumatic dizziness, which again, there's at least 7, 8 reasons people can be dizzy after trauma, as there are multiple reasons why people can have headache, most of which have nothing to do with brain injury, but have to do with trauma. Number 2, you have to examine patients to treat post-traumatic headache. 90%, this is just anecdotal, 90% of the patients I see in tertiary care for headache, when I ask them to disrobe and they lay down on the table and I start palpating their neck, shoulders, head, face, jaw, they say, "What are you doing?" I say, "Well, I'm examining you." And they say, "Well, nobody's ever done that before." So touching patients is part and parcel of doing a good job at assessing post-traumatic headache complaints. You can't do that without touching the patient, shoulders up being the most critical. That's a biggie in my book as far as a problem in the field in general, at least based on talking to clinicians and to patients over the years. The methodologies for treating headache are so numerous now. Just as migraine as an example, when I started this, there was a handful of drugs that we used for treating migraine. Now there is a plethora of medications available, and newer ones just coming out in the last few years that have a very high level of efficacy, as well as new techniques with what I mentioned before with neuromodulation that are being used for headache management, including things like cephaly, vagal nerve stimulation, occipital nerve external, as well as implanted, which I'm not a big fan of, stimulation. And then new devices like the Israeli designed device Relivion, which is just coming onto the market and is FDA approved, and combines supraorbital, supratrochlear, and occipital nerve stimulation with an external device that you wear on your head. So there's some pretty cool stuff going on in headache management. But as I said, there's multiple types of headache, and you can have mixed headache pictures. So you can have a patient with cervicogenic, meaning coming from the neck, contributors to the headache, that the problem's here, but is felt in the head. You can have migraine, you can have tension headache, you can have neuritic, neuralgic headaches, meaning coming from nerve injuries, like with direct impact injuries to the scalp. So there are many different things that clinicians need to be thinking about in the context of taking a good headache history and doing a good headache exam. There's a nice chapter, I didn't write it, but there's a nice chapter in my latest edition of Brain Injury Medicine that discusses the whole arena of post-traumatic headache, from assessment to management to pathophysiology, et cetera.
Do you have a copy of the book here?
I don't, but I can get it.
Okay. And is this a book that a layperson could understand? Or
Possibly, but I'd say it's written more for a medical audience.
Hello?
Can you bring me back a copy of the 3rd edition,
Sure.
please?
Yep.
Sorry.
no,
Go
I
ahead, Catherine, I'm sorry.
love to see it. I've seen the table of contents, but I haven't seen the book itself. From the 1st edition to the 3rd edition, what changes have been made in the book that excite you?
Well, I know the changes that have been made in me, and my hair's a lot grayer, but as far as the book, we've expanded the content and moved.
That's a big book.
It's actually not as big as the 2nd edition because the references have been all put on the web. There's a web version or e-edition, and only the key references are in the book. So each author was asked to pick, their 10 or so key references on the subject matter. but there are many, many, many references that you can further access on the web, as well as some supplementary chapters, including an excellent chapter on patient resources that I wrote with Dr. Michael Martelli. And Marilyn wrote a chapter from the family survivor perspective.
And I actually did read Marilyn's chapter. She shared it with me, and it was great. And I'm so happy that her history will be preserved in that way. So
yeah,
that's great.
As was I, and I really had to push her on that, but I'm glad that I did, and I'm glad that she was able to contribute.
Yeah, and it is a great chapter. Is there any thought of taking what is in the book and creating a patient kind of guide to it in a way, or key point takeaways that patients can use?
If you want to do that, I'm happy to talk to you, but I don't know that it was on my agenda. For what it's worth, a book like that is a multi-year project, and we've done one about every 5 to 7 years for the last 3 editions. Plus, I did the predecessor of that with Dr. Lawrence Horn, who was one of my mentors. I don't know if you know him, or if the folks who are on the call know him. Recently retired. Larry and I did the first book really on medical rehabilitation of traumatic brain injury that was focused specifically to medical issues. And that was published by Demos, if I recall.
Did you hold the book up again? I'm getting people texting me. We didn't get to see the book, so they want to see the book again.
You can find it on the web.
Brain injury medicine. Okay.
You can probably get it cheaper in certain places and it's more expensive in others, but it's Brain Injury Medicine, Principles in Practice, 3rd edition, with Springer Publishing digital access.
Now, that would be for doctors, rehab professionals. What are the range of people that book would be suited for?
I mean, I would say rehab professionals, therapists, neuropsychologists, psychologists, nurses, social workers, physicians, not specific to rehab, but any physician involved with brain injury care.
It's amazing to me how someone can be in the medical field and have literally had, a few hours on brain injury care. You cannot assume that doctors have that piece. Is that an issue with medical schools needing to increase the number of hours that they're training, or is that a post residency responsibility for doctors to keep up with?
Well, it's an interesting question that you asked. And again, you're getting one person's opinion here. I'm not going to say there's consensus or that anybody's written a good paper and taken a big poll of people to have an answer. But my own opinion is the following. Number one, you get little to no information in medical school, not residency, about TBI or acquired brain injury in general. In residency, depending what residency you do, whether neurology, neurosurgery, physiatry, and depending where you get that training, the amount of brain injury exposure can vary significantly. For physiatrists or physical medicine and rehab docs, you have to have now some brain injury exposure. But I think the realities are that there aren't enough of those kind of docs around to go around and meet the needs of all the patients that are out there. So what ends up happening is they're being seen by primary care physicians, pediatricians, ER docs, sports medicine docs, who some have better knowledge than others, and some don't know much about concussion or more severe brain injury. So I think that there has to be some mechanism to better educate the medical community at large, whether at a local, regional, or larger level, to include didactic opportunities specific to working with patients after claimed brain injury, and being able to say, yeah, more likely than not, this person had a brain injury, and then know what to do about it or who to refer to. I would just mention, and people may know this already, but in 2014, after many years of and efforts to do so, led to a great extent by a colleague of mine, Betsy Sandel, who you may know, Catherine, and other people may know, kind of spearheaded an effort to have a subspecialty certification in brain injury medicine, which has been available since 2014 for the disciplines of rehab medicine, neurology, and psychiatry. So if you are a specialist in any of those areas, you can sit for that subspecialty certification, which again, doesn't make you an absolute expert, but it makes you probably a better clinician to consider referring patients to than somebody who doesn't have that subspecialty certification. And again, I'm not saying it's necessary. If somebody's known to be good in your community and doesn't have that, then obviously I'm not going to say that's a obstacle to referring to that person, but just to mention that so folks are aware that it exists. And there's a listing on the web that you can find the subspecialty certified docs in brain injury medicine in your own community if they exist. I think
is that international? Because I know we have some Canadians on the call.
To be honest, I don't know if it's international, but the list has, I think now probably over 600 doctors who are subspecialty certified in that area.
It leads me to my next question is, do you want to tell us a little bit about the Disorders of Consciousness meeting coming up in December?
I'm happy to do so. We have a number of subgroups in the International Brain Injury Association, including one on disorders of consciousness. It's probably been one of the more active groups. We've published a number of studies over the last 3 years or so in multiple international peer-reviewed journals. The group itself, as far as those who are actively participating, is not huge. It's probably maybe 50 people, but there are quite a bit more that are on our email list and have signed up to be on the DOC special interest group. I think it's an exciting group because it's an area where we're seeing lots of advances in knowledge in terms of both assessment and treatment. This is our first meeting as a special interest group, so it'll be pretty exciting in that sense. Again, because of COVID, it will be virtual this time around, which actually I think offers some nice opportunities of access to people who might not have otherwise been able to attend the meeting because of changes in reimbursement for travel that many institutions have implemented, at least in this country, and limitations in CME funds and CE funds in general. So I think the virtual format has some advantages in that sense of increasing potential access across the board to people interested in attending, whether clinicians or otherwise.
And what range of people would you suggest to attend that meeting?
What range is in?
I'm sorry, what range of professions? Would a social worker and a rehab professional, or would you say that would be more of neurology? Like what's the audience for this upcoming conference?
I mean, I think any professional who interfaces with families, patients, other clinicians who are involved with assessment and treatment of persons with disorders of consciousness, coma, UWS, minimally conscious state, would be appropriate to attend the meeting. It has obviously a more neuromedical slant to it, but there's also some ethical and psychosocial things included in the meeting.
And I think, haven't we also seen that advances that were done with advances that took place with moderate to severe TBI, over time, some of those are brought to mild TBI, like with the eye scanning, and that there's a flow between these moderate to severe that is helpful to understand as you're dealing with families?
Sure. I mean, I think they're different animals in many ways when you compare the most severe end of the spectrum with the milder end of the spectrum. And, people who specialize in dealing with disorders of consciousness generally don't also see patients with concussive injuries. You either do one or the other. It's rare to see people doing both, just inherent in the knowledge base required to do one versus the other. But I think certainly there's translation, at least to some extent, of some of these assessment and treatment techniques across severities, which again, that's also another conversation, but there's a whole discussion ongoing about changing the way we label individuals who have brain injuries and finding different terminology than mild, moderate, severe to describe that population of patients.
Yeah, no, I think it definitely gets hard. And I wonder, like in the cardiac field, are there certain doctors that within cardiac illness, cardiac disease specialize on the mild end and others on the severe end? Is brain injury unique that we have these sort of two sides of it and you're on one side or the other?
It's an interesting question. Again, my own opinion, as I stated, is that you tend to do one or the other, or lean more towards severe brain injury because you're an inpatient-based clinician. There are people who certainly do both, but I think the general tendency is to lean one way or the other.
Yeah, no, it's definitely a fascinating field, and I am happy to, as a social worker, be somewhat of an interloper, but be able to be in this space and learn from everyone.
You're not an interloper. You're part of the team.
Well, thank you. You've always been supportive of what we've been doing here. And I do know we broke the bank at 100 viewers at one point there. So I did want to open it up. The doctor, of course, like all our other guests, can't specifically, if you are a person with lived experience, can't comment on your particular case. And because there's so many people on the call, if you could just start with your name, where you are, and my question is, and we just don't have time for a lot of backstory. So that would be great. And Kara, have you read through the questions? And maybe every other question, maybe Kara, read one. If you want to put your hands up, I'm changing my view, exit full screen. Does anyone have any questions off the top of their head that they would like to ask, raise your hand, or you can unmic. Kara, do you have any?
That Lori Rapon wrote a question. And how do we get more stakeholders involved in the major brain injury conferences? And that it's rare, but very important to get the professionals and those affected by brain injury talking to each other. Do you have any thoughts on that?
Both good comments / questions. Again, I think stakeholders inherent in the name have or should have an interest in being involved with those kind of conferences and sending their staff and educating their staff about the advances in brain injury. I think, again, it comes down to economic decisions a lot of the time. This is, again, my experience, having been involved regionally as well as nationally and internationally with a multitude of meetings over the years. Everybody has an agenda from the stakeholder standpoint, and if the meeting doesn't meet that agenda, then you're going to have a hard time getting people to support it financially. So I think the more education there is about why it's important to be involved and why it's important to support this particular effort that you can provide, the more likely it is that stakeholders will chip in to the pot, so to speak. What was the second part of the question? I'm sorry.
to get the professionals, to get them talking to each other and I guess collaborating
I went,
with each other. Oh, Laura, go ahead.
I just that especially in the time of COVID, those are much cheaper. And I know I went to ACRM, but to get there was really, they were like, oh, we actually don't have anyone with brain injury on our committee. We'll have to think about this. And I think there were very, very few. So I think you have to look at it from the other side too. It's a rare thing for, not for all of them, but certainly some of them. So it goes both ways. And now that a lot of them are virtual, it's much cheaper.
Right, and that was my point earlier, Lori, that the virtual nature of the conferences has really facilitated opportunities for everybody, whether someone with a brain injury or professionals, to participate in these meetings and gain knowledge and information. So I'm personally a big advocate for continuing virtual access, even when hopefully COVID is no longer an issue and we can all network with each other face to face and give each other hugs and kisses, which hopefully one day will come about. But right now, virtual has become the way we do things. And I think it's a good way to continue to facilitate access for people internationally who want to attend these meetings, because we get emails all the time at IBIA saying, I'm from Tibet and I have no money to come to the IBIA meeting, but I really want to come. Can you give me $5,000? The answer is no, I can't, but I can offer you a virtual at like 1/10 the price of what it would cost you otherwise, and never mind the travel and the hotel, which you avoid as well.
And I actually like the one-off nature. I did a 45-minute talk for Tulane Medical School last week. And I really like the one-off events as opposed to the sort of longer things. I do think it's hard to kind of shut down for 3 days and focus like you could at an event. But I really do like these one-off sessions. Poor Deborah's had her hand up the whole time. Deborah, what was your question? You're muted.
Your mic, Deborah. You're on mute. Oh, no.
You get A for effort for holding your real hand up the whole time.
In answer to your question, Catherine, I think the issue is a lot of people who have jobs and don't have control over their work schedule, it's very difficult for them to take off 3 days and attend a meeting virtual, never mind in person, because then you have travel as well and other costs. So I do think there's an advantage for the more limited educational opportunities, but not at the sake of losing the other opportunities as well.
I can't tell you how many people I have chased down in elevators. I jumped into a cab once with Dr. McCree. Like I literally have, hi, can I just ask you a question? So that I think that one-on-one is so important, but I do like your idea of the hybrid in the future. Allison, you had your hand up, and Deborah's, sorry, you're unmuted, Deborah.
Oh, I'm unmuted. Thank you so much. I wasn't sure how to get that unmuted. You mentioned 3 new approaches, I believe, and my notes are horrible. I apologize. But one, you said gene-related therapy, and then you talked about inflammation and neuromotor. When you mentioned gene-related therapy, are you referring to possibly stem cells or?
Well, genomics in general is a broader category of research looking at various correlations as far as genetic risk factors, for example, for outcome, ApoE, as an example, among others. But okay. Again, it's not at this point, it's more in the lab still, but I think it's an exciting development. I mentioned the other ones as far as neuroinflammatory pathways and what we can do pharmacotherapeutically to interrupt those to improve neurological outcome. And then I think the third one I said was neuromodulation, right?
Okay, I put neuromotor, but you might have said modulation.
Yeah.
Okay, thank you. I am I worked in the field, and then now I am a survivor of a mild traumatic brain injury. And I got to a DO about 3 years ago. My car accident was 12 years ago. And she did cranial manipulation,
Craniosacral.
craniosacral manipulation. And then also she adjusted my eye socket because I hit both eyes in my accident, plus the side of my head. And that's helped me a lot. But I am just craving any information I can get on ways I can improve and get better. And I have prisms in my glasses. So
If you don't mind me asking, did you have headaches that improved at all with the DO intervention?
yes, I feel significantly better. And my GP, he's noticed such an improvement in me. And I've been in speech therapy. They've noticed an improvement in me. I'm not close to my normal, but I am very thankful to be where I'm at. But I just crave information like this. So thank you.
I don't like the word normal. Nobody's really normal.
I said my normal.
Okay, well, that one I'll buy. On the comment that Deborah made, I just make an extension comment, and that is that I think manual medicine skills are highly valuable in treating people after these kinds of injuries. You just think about what happens to people in terms of the biomechanics of these injuries, both to their head, to their jaw, to their neck. I can tell you I've treated many a patient that an upper cervical manipulation relieved their headache, and nobody had touched their neck previously.
Yeah.
So manual medicine skills, whether by a DO or someone else appropriately qualified and experienced, can be very valuable as part of the treatment armamentarium of the clinician.
I was totally impressed because during your conversation today, you mentioned touching them. And I thought she was actually the first person that touched me. I mean, kind of.
There you go.
And you do that. So I was totally impressed.
Would you see those cervical and neck issues more in women than men? I mean,
Yes. And you know why?
do you think neck to head ratio?
Yeah, its anatomy is different. Women tend to have thinner necks, less muscular necks, or more prone to cervical injury.
And I guess that's always been known in the automobile field of auto accidents, that women's injuries post auto, but it just didn't translate through the brain injury field.
Well, there's actually, Katherine, recent research. John Letty and his group, Ellis, have published, and I've been talking about this for 20 years, about how important the neck is in the context of differential diagnosis of post-concussive symptomatology, much of which comes from neck injury and whiplash. And if you don't know whiplash, you can't really treat these patients particularly well, because whiplash can present with all kinds of symptoms that overlap with post-concussive symptomatology. Sylvie has a question.
Oh, Sylvie, and then I'll call on Allison.
Oh, I'm not supposed to do that. Sorry.
No. Sylvie was, I think Allison will understand.
Okay. Hello, and do you hear me?
Yep.
Are you fine?
Okay. Thank you for this conference. I live in Canada, in Ottawa, Ontario, and I am a patient of brain injury, severe. I was noted that it was severe. I cannot work since 3 years. So, and I was very, very active. I have a full profession, liberal in the government, federal. And anyhow, my question is, you have talked about advocacy, that people need to be more vocal about this, and anyone who work on the field. And for me, my question is, when I told people I cannot work because, well, I am on disabled leaves because I cannot work because of my brain concussion. I was diagnosed with disorder cognitive after my post-brain trauma injury, concussion. Okay, and people ask me, yeah, but hockey player, football player, they have plenty of concussion and they go back to the field. So why me? So sometimes I receive, not often, but I'm lazy, I don't want to work. I play with the system because it's not physical. It's
Right.
not apparent.
I was going to say, Sylvie, that it's very common for patients who have, silent brain injury, in the sense that you're not walking around with a limp, or your arm's not up like this, or you're not slurring your speech. So somebody looks at you and talks to you and says, hey, this lady's fine. But you're not. And the issue is that often the cognitive and behavioral consequences of brain injury get overlooked or overshadowed by your, I'll use the word that I said not to use, your normal physical appearance. And part of the challenge is making people understand that disability goes beyond physical disabilities and can affect people at other levels, cognitively, behaviorally, language understanding, etc. That's easy for me to say, harder for you to do as the person with the disability.
I experienced it with my son's concussions, which he had just sort of life-changing concussions, one after another. No one really did anything for us as a family. And then I had a concussion, and then I had cancer, and literally within like 24 hours, if even shorter, of announcing that it got around that I had cancer, people were bringing food and religious objects and flowers and offering to do things. The same people, but we just don't, as society, I think, know how to respond to brain injury the way people naturally know how to respond, especially something like breast cancer. So that, as an advocate, I really try to share that story to say, if you know somebody that has a brain injury, can you support them in a similar way? And I do think that's very hard. We're getting close to our time, so we'll do more rapid fire. Allison, I know you've been waiting, and then Sharon.
Great, thanks. Hi.
Hi.
I am a professional, and then I'm a nurse practitioner and a brain injury specialist, and I'm also living with persistent concussion symptoms for over 3 years. And my question was about your practice. I think, if I understood you, you alluded to putting some space between your practice and the sort of mainstream system. And I would love to know more about what your practice looks like now and the changes you've made and what that means.
Well, in brief, it's a fee-for-service practice. I have it's a small practice, but a specialized practice, a physical therapist who specializes in orthopedic and vestibular rehab, very good with whiplash-associated disorder and vestibular problems. Dr. Thies, who lectured the prior week, who's a neurooptometrist, and Dr. Wexler, who's a neuroendocrinologist. Richmond is actually an interesting town because we have a lot of brain injury expertise, because the program at VCU, led by my colleague and friend, David Sifu, is one of the top programs in the country and has been very productive in terms of grants over the years, dating back to when Donald Becker was here in the 70s in the Department of Neurosurgery, and then Henry Stonington in the 80s, and then Dave in the 90s and forward. So there's a lot of docs who are brain injury specialized, Greg Oshanik being a neuropsychiatrist who's nationally known, who was medical director of BIAA, among others.
Great.
Do you think COVID will increase the number of the COVID money and the long COVID? Do you think in a way that will create another stream of revenue for brain injury rehab and brain doctors? Or do you think it will stretch the service?
It has already, Catherine. There are doctors who are focusing on long haul COVID neuro symptoms. Again, it's going to become a specialty area, I think, in and of itself, is my prediction. I don't have the crystal ball. Allison, did you have another part of that question?
No, I think that was it. Thank you.
Okay, you're welcome.
And Sharon, you have your hand up. Are you able to unmute? Sharon Nolte?
Is that right? Did I do that right?
You did, hello.
Hi, I don't want to be on the screen because I pulled over and anyway, but this has been the most wonderful event, Catherine and Doctor. I'm crying. I'm so excited. My
I didn't
question,
mean to make you cry.
well, in with wonderful tears of joy.
Okay.
I have just come from a cranial sacral therapy. I have mild traumatic brain injury. I've had vestibular disorders, and I'm asking this question, which have been corrected, and prisms, et cetera, et cetera. But cranial sacral therapy has been the only thing that really has worked. And as you talked about the manual, whatever, but it is not covered by insurance, and it's expensive, and what do we do? How do I advocate for it as a profession? I mean, for myself, but for everyone. It's frustrating beyond belief.
Well, I'll say this, and it's not germane specifically to craniosacral therapy, but there are a lot of things that we as clinicians have to fight for to get to treat patients, whether it's a particular medicine that's off-label and not FDA approved, but there's consensus experience in the field that it may be effective, like Namenda for neuropathic pain, as an example. Like use of dry needling, if people are familiar with the
Right.
technique, which is done mainly by physical therapists. But interestingly, there are some states where it's not legal to do dry needling by physical therapists. And we just had a patient where there was a denial for dry needling services in my practice, that there's no reason that it should be denied. So I think my answer to the dilemma is there's only so much we can do, but the things I would try to do is ask your clinician to write letters to the payers about the medical basis or literature that supports the particular intervention, treatment, etc., that is being denied. That's number one. And the more literature that can be provided and the better letter that can be written, the more likely it is that denial will be overturned. But there are going to be some things that insurance companies, again, if you're dealing with insurance, which is where the difference is between going in and private paying, which I understand some of these things are expensive and beyond affordability for a large sector of the population, is that insurance companies, if you look at their sites, have specific policies about this is a experimental treatment or a controversial treatment, and at this time it's not considered medically appropriate and we're not going to pay for it. That's what we're all dealing with on multiple levels in terms of providing patient care. But again, the more science there is behind the interventions that we use, the better, which is one of the reasons why research is so important to continue to address all these issues. And there's multiple areas where the research, I'll use the word stinks, is scarce, but yet the practice is common. Craniosacral is one of those areas where I think we can do much better as far as prospective controlled blinded research.
You see any way that like non-clinicians, whether it's like advocates, social workers, I'm an advocate with pink concussions, survivors, can work to, I guess, advocate and increase coverage and do all of that without going through their doctor who may or may not agree to do so?
Well, if you have a doctor who's not willing to advocate for you, my opinion is think about changing doctors. That may be a strong comment, but that's my feeling, that it's part of our obligation as a healthcare practitioner, whether a doctor, neuropsychologist, whatever, to advocate for our patients. So if people aren't willing to write letters or go to the literature and pull literature to justify what they're recommending treatment-wise for you, I think that's a problem. And it's a problem that I think is somewhat endemic in the system. Doctors don't like to be asked to take more time to write letters that they're probably not going to get paid to take the time to write.
Speaking of time, doctor, it's 3:01. Do you have a hard stop at 3? Because I don't want to make you late for your next.
Yes, Margaret Roberts is going to get mad at me because I have a conference call on the inaugural National TBI Registry Coalition.
Awesome. That's great. I didn't want to extend beyond. I do, because there are so many questions. I really appreciate. Can you do a 20-second pitch for Dr. Wexler?
Dr. Wexler. Dr. Wexler is a lovely, younger, very bright neuroendocrinologist, MD, PhD, who is kind of the go-to person nationally for neuroendocrine problems after TBI. I think you'll find her fascinating, and the area is way underappreciated as far as the impact that it may have on function following TBI, not just in terms of hormonally, but cognitively, behaviorally, etc. So I think her talk should be highly anticipated.
That's so great. And now, if you have comments or thanks that you want to put in the chat field, I know people have said sorry that they had to leave and how interesting it was. So I'll make sure that the doctor gets that chat field and so can see all the compliments. I really want to thank you for your time. I know you're incredibly busy and really appreciate you spending this hour with us to discuss these things. And good luck with the disorders of consciousness. I will be hopefully there tweeting and adding some social media to get that information out. And if anyone wants a copy of this, probably by Saturday, I should have this up on the Pink Concussions YouTube channel.
Great.
So any final words?
Thank you, Katherine, for the opportunity. And I hope it was beneficial for those who attended.
Oh my God. Oh, thank you.
Thank you.
Awesome. All right. Thank you, everybody. And see you next week for Dr. Wexler. And we'll keep the chat open a little longer and we'll let the good doctor go to his next call. Thank you so much. If anybody else wants to put anything in the chat, because there's some really good questions. I really wanted to get to Jose's question, but I've learned if we keep these people too long, we won't get them back again. So hopefully we'll have him on a part 2, maybe right before the next conference. So everyone have a great and safe day. Thank you to everybody for coming on the show again, and we'll see you all next week. Take care. Bye-bye.